Okay, so we have a couple of people that just joined us. And again, I'm excited. I'll say again, we have CPHEN on the line. I feel like a DJ. It's like CPHEN on the ones and twos. And I am really excited to have them. Way back, I would say, when I even began to enter my public policy journey, CPHEN was an organization that immediately attracted me for their advocacy and their outreach and their community engagement from a multi-ethnic lens, quite frankly. So I am just really grateful to have them at the front lines of this work and interested in continuing to educate the community about the work that's being done in a policy space. So, without further ado, it looks like we have a good quorum of expected participants on the line. So, I'm going to just do a quick introduction so you know who are going to be your presenters today, and we'll hand it over. But we have Natalie Lupin, who is a senior policy coordinator at CPHEN. Before joining CPHEN, she completed her master's in public health at UC Berkeley, where she specialized in maternal, child, and adolescent health. Natalie is committed to advocating for marginalized communities and using her privilege to amplify those who often get left behind in the health system. She is passionate about advancing inclusive health research and data collection, ensuring that community members' voice and lived experiences inform health policy. Her work is guided by the principles of continuous learning, humility, and compassion. Natalie's background in public health evaluation, research, and health policy drives her commitment to addressing health equities in California. And prior to graduate school, she worked at Mathematica, where she focused on evaluating health programs and conducting policy research in this role, she contributed to the Rockefeller Foundation's COVID-19 Equity First Vaccine Initiative and developed Medi-Cal policy recommendations focused on preventing intimate partner violence. Prior to Mathematica, she worked at the National Academies of Science, Engineering, and Medicine, where she planned health policy conferences and wrote policy recommendations aimed at improving the U.S. healthcare system. In her free time, Natalie enjoys going on hikes with her dog, taking dance classes, spending quality time with family and friends, and cooking new meals. So, presenter one, as you can see, is very qualified. So, we are excited to have her. And I think uniquely ready to participate with this session, which I would also say about Samantha. So, I love reading the bios because it's like you get to really it's like a brag, but it's all true. So I just enjoy it. But Samantha Schwimmer is a community activist and an artist from San Diego, California. She is the Southern California regional organizer at CPHEN. She also serves as the chair of the board of the San Diego Coalition for Reproductive Justice. And prior to CPHEN, Samantha worked for the San Diego LGBT Community Center, San Diego Legal Aid Society, and Planned Parenthood Maine Action Fund. Samantha has a BA in religion and anthropology from Bowdoin College. And in her free time, she enjoys cooking with loved ones and watching San Diego Wave FC. So, without further ado, I want to turn it over to Samantha and Natalie to begin our presentation. Welcome.
Thank you so much, Amber, and thank you to all of you for being here with us today. We're going to be talking about some heavy topics, and I think just really grounding ourselves in this space of, the power in community is how I really want us to start off, just acknowledging the amount of different folks we have in this room and all of our shared knowledge. And I think in this room, if we keep talking, like, we will find a lot of answers to the problems we're going to talk about today. So just grounding us in that. But today's presentation, we will be talking about the recent Medicaid cuts, specifically through a reproductive justice lens. And yeah, I think we've done our intro, so I think we can kind of skip over that slide. But could you go back one? Sorry. I'm just gonna quickly intro CPHEN, just so folks know a little bit more about us. So we, the California Pan Ethnic Health Network, we were founded in the early 90s in response to the LA riots. A time of great division amongst communities in Los Angeles. And we were founded by 4 racial equity organizations to intentionally work across cultural lines to address health inequity. And so really a lot of our work is rooted in multi-ethnic organizing, multicultural organizing, and now we've grown into a pretty robust policy advocacy organization with offices in Sacramento, Oakland, and um, Los Angeles. So our work spans across the entire state, which we'll talk about a little bit more today. And like Natalie just said, we would love to get to know who was in this room and in this space. And so if you don't mind in the chat going ahead and introducing yourselves just with like your name, your pronouns, your org, where you're living, or where you're calling in from, just so that we kind of have a sense of who's here. That would be great. I'm just going to quickly go over the agenda and learning outcomes, and I'm going to pass it over to Natalie. So today we're going to be doing just some grounding and background, which we've already kind of just done. And then we'll be talking about HR1 impacts on health and on birth workers. And then we're kind of going to end with a bit of a call to action and just talking a bit about the work that CPHEN and our partners are doing and how you all can get involved. So next slide, please. Great. So at the end of today's session, we hope that you all are able to identify at least 2 ways the passing of HR1 may impact healthcare services, especially among maternal and infant health community birth workers. That you'll be able to describe at least one example of a collaborative, community-led effort aimed at shaping or influencing health policy, and that you'll be able to implement a new civic engagement strategy designed to reduce the negative impacts of Medi-Cal funding cuts on vulnerable communities. So those are our learning goals for the day. And with that, I will pass it off to Natalie.
Hi everyone. So yeah, I'll be going through and kind of talking about HR1 and its impacts on health and maternal child health, and birth workers. But first, I kind of just wanted to open it up and make this a little more interactive. And so just opening up with a question, and there's no right or wrong answers. A big goal of this is to, teach you all or and give some more input. So if you don't know anything, so just opening up, feel free to raise your hand or put a response in the chat. But who has heard of HR1, or also known, unfortunately, a lot about, called the One Big Beautiful Bill? So raise your hand if you've heard of it, or put something in the chat to say, yes, I've heard of it, or I know what it is. Seeing some thumbs up. I see some other yeses in the chat. Yeah, so it seems like there's some familiarity with it. Yeah. Seeing some more yeses in the chat, some surprised faces. Um, awesome. And then wanted to give any space, just it could be really high level too, but open it up to someone on the call to come off mute and share a little explanation of what you know about HR1 before I dive into it. Totally understand if people are a little bit shy. Part of the point is I'll be explaining it all too, but I guess to give one more shout out if anyone, if you said yes in the chat or raised your hand, does anyone feel comfortable sharing a little bit about what little explanation of HR1?
Or maybe we could share, I don't know. I was going to say what we want to know, but this might be the point. Like, there's a lot of unknown, right, Natalie?
Yeah, and that's
Can I
okay.
share? Sorry, is it okay if I share?
Absolutely, go ahead.
Um, I don't know a lot. I kept meaning to read it and then never got to it, but I believe what I've heard about it is that it cuts, there are definitely tax cuts for the wealth hoarders, and a lot of funding for Medicaid has also been cut. And it's this nonsensical doublespeak of, oh, the government is overspending and we have to save money. And so the way that we're going to save money is to cut supports for the most vulnerable and marginalized amongst us. and give tax credits for those who hold the most power, privilege, and money, because those poor wealth hoarding folks need all the support they can find.
Yeah, absolutely. I think you nailed it. That's exactly the gist of what HR1 is. Thank you so much for explaining that. Um, and yeah, using the term wealth hoarders, like that term. But yeah, that's kind of exactly it. And in terms of, it's a really, really long bill, and part of what we're going to do today is kind of break down and go into some of the details of what it actually means, because they made it so long and complicated. But that's, if you take away anything from this training, I think exactly what you just shared is a good thing just to understand about HR1. Okay, now I'm gonna go into, you can go to the next slide, please. I'll go into all of the HR1 impacts on birth work. And before going into that, I just want to share a couple notes before I get into things. So first, throughout the presentation, I might use the term Latine, and just want to make sure everyone is understanding of what that term is. It's a gender neutral version of the term Latino that originated from the LGBTQIA+ and the gender non-binary and feminist communities in Spanish-speaking countries. So I'll be using that, and maybe that's something, a new term that you all learned today. Additionally, in some of the impacts and findings that I'll share, I just want to flag, that I'll be naming Asian communities are among of the groups that are being disproportionately impacted as well. And just to note that oftentimes it's hard to see this actually in the research because Asian communities are often aggregated into one group. And so it's really hard to see that full narrative in subgroups such as Filipino communities and others. And so I'm really trying to be as inclusive of this as much as I can throughout. So just wanted to kind of name those two caveats ahead of time. Go on to the next slide. And so to get us going, just to kind of continue on with a little bit more interactive, I'm going to start us off with a bit of a game about HR1 fact check. And it will be an interactive way to kind of build our knowledge together. So before I get into the first question, just you can type your answer into the chat. And as you saw, all questions will be multiple choice. So, you can just type in A if that's the answer that you think is correct. So Josh, move to the next slide. So when was HR1 signed into law? We have A, January 1st, all of these in 2025, B, March 15th, C, July 4th, and D, August 31st. We'll give people a couple minutes to think about it and respond. And again, this is all about a learning space and just a different way to kind of hopefully help learn some of this knowledge about HR1. Seeing some Ds, so potentially recently in August, I'm seeing some Cs, July 4th. Yeah, looks like we kind of have a generally even split between those two. Go ahead and go to the next slide. We'll see what the answer is. Yes, so for those of you who said July 4th and C, that is correct. That's when it was passed. It was not a very happy 4th of July celebration for a lot of people. And this, personally for me, is a big reason. CPHEN was closely tracking it, and it was a very quick, the legislators spent overnight voting and really pushed for it to happen by the 4th. And yeah, we didn't think they would pull it off, as Samantha said in the chat. And unfortunately they did. They keep doing things that, we never thought was possible. Next slide. Other question, over the next decade, how much does HR1 cut from Medi-Cal? So a couple different answers: 250 billion, 500 billion, 850 billion, or over 1 trillion. What do people think? Okay, some people are thinking C, 850 billion, seeing some more C's. B, 500 billion. And also, just note, all of these are, high numbers. So we know that these are pretty big cuts. I'm seeing a D, over 1 trillion. Give everyone one more, maybe like 30 more seconds. Another D. Yeah, you can go ahead and move to the next slide. We'll see what the answer is. And it is D, unfortunately, over 1 trillion. And again, just kind of reiterating what was said earlier in the explanation, these deep cuts help fund tax breaks for corporations and the wealthy, and all while stripping healthcare from low-income immigrant families. So it's really, really a horrendous bill. And it's a lot of money. Again, over 1 trillion. I think at this point, these are just estimates. We can't even fully comprehend the full ramifications. Next slide. I think we have 1 or 2 more questions. So how many Californians are expected to lose Medi-Cal and covered California coverage under HR 1? So A, 1 million. I think I don't have to read them all out loud. But they progressively go up in numbers, both for Medi-Cal and covered California. I'm seeing a D, so kind of the highest amount. And again, at a baseline, we know that a lot of people are going to be losing insurance coverage in both Medi-Cal and covered California. Yeah, Medicaid. And so Medicaid, Medi-Cal is just the California name for Medicaid. Apologies if that was confusing. Yeah, so seeing kind of a bunch of different answers, B's, C's, and D's. Joshua, you want to go to the next slide and share the answer? Yeah, fortunately, it's one of the higher numbers. So an estimated 3.5 million people in California are expected to lose Medi-Cal coverage, and 660,000 people under covered California are expected to lose coverage. And what's really important to note is who is this disproportionately affecting, and it's immigrant communities, especially Black, Latine, Indigenous, Asian, and Pacific Islander communities will be disproportionately impacted by these coverage losses. So really, really an attack on all of these communities. Okay, next slide. So done with the game, and now I'll just start to share some more about these details. So HR 1 is a direct attack on birth equity. All of these coverage losses will have direct impacts on the communities that you all work with. And so these impacts of people losing coverage, so more clients are going to be without insurance coverage, as we just mentioned, by all those numbers. People being kicked off of covered California and Medi-Cal. This will have a trickled effect into delayed or no prenatal care for individuals, also limited or no postpartum care, and also ultimately higher risks during birth. And so now I'll go into some details of what HR 1 actually does policy-wise and those impacts. So next slide. So HR 1 strips healthcare coverage from many immigrant families. Some specifics, lawfully present immigrants like refugees, asylum seekers, trafficking and domestic violence survivors, they all could lose Medi-Cal and covered California access. Additionally, DACA and temporary protective status, also known as TPS holders, will be blocked from Medicare and health coverage subsidies, like covered California. And even lawfully permanent residents, so individuals who have green cards, will still have to wait 5 years before they can get full Medi-Cal coverage. HR 1 keeps this barrier in place, and it makes it harder for families to get care when they need it. So what does this all mean in practice beyond just the policies and the acronyms of who are these people that are being impacted? These coverage cuts don't just affect individual families. They directly impact birth workers and the communities that you serve. And so when families lose access to Medi-Cal or covered California, they're not just losing insurance, but they're also losing access to birth workers, to doulas, to midwives, to postpartum care, and the trusted, culturally grounded support systems that keep birthing people safe, and all of the amazing work that you all do in your organizations and with your communities. It's really going to have a lot of impacts. Next slide. Also, feel free, folks, if you have any questions, we'll hopefully have time for questions at the end. But also you can feel free to come off mute during the presentation or to put some questions in the chat, and we'll be monitoring the chat throughout. So what's also going to happen under HR 1? They have new work rules that will create even more barriers to accessing Medi-Cal. So starting in 2026, adults who are 19 to 64 years old must prove that they have 80 hours of either work, school, or volunteering, and every month in order to keep staying on Medicaid. So that's huge. So one, that adds bureaucratic hurdles that can push families and individuals out of care. Again, doing that every single month, that is a lot. Additionally, it's key to note that pregnant people, so they are exempt from this. However, once, an individual has their baby, during the postpartum period, they are not exempt. And that puts people in a very difficult position by potentially not having any health coverage during such a critical period. I think we all know that that is, a time where there's needed a lot of healthcare support, mental health support, and it's not just all done once you have the baby. So that is really, really awful. Yes, postpartum people are not exempt. And so, again, kind of just emphasizing some more impacts on birth workers. Families may be losing coverage right after birth, like when I said, when it's most critical. And birth workers, your work, your partner's work, community members' work may be left trying to help navigate this broken system. I know that people will still be trying to give that support, but without actually, the insurance and the funding and all of that in place. Community services supported by initiatives like the Perinatal Equity Initiative also could be disruptive. If families lose coverage, this could put equity-focused programs at risk. So a lot of trickle-down effects, which is so awful. Next slide. And yeah, I hate how these are all really disappointing facts to be sharing. And we'll move towards action towards the end just to share. So overall, HR 1 increases healthcare costs, which in turn creates more medical debt and also hospital closures. So HR 1 will end premium subsidies, making coverage more unaffordable for many. More families will then go into medical debt, or as I mentioned earlier, be uninsured. And also this can increase the number of rural hospitals, specifically in California, that are at risk of shutting down due to loss of funding. And so specifically in California, there are 34% of rural hospitals are at risk of closing, which is means in the next 6 to 7 years. And then 10% of rural hospitals are at risk of immediate closure in the next 2 to 3 years. And so we already know, well, one, there are some rural hospitals in both Riverside County and Kern County, which I believe some of you all are from or work in that spaces. So something to know and maybe to kind of keep updated on. But, there's already, before HR 1, there's already been a serious issue, particularly in rural areas of California, of, labor and delivery units closing and hospitals closing, and individuals having to travel much further for any perinatal care. So this is just unfortunately only going to get worse. And so there's going to be less access to safe birth spaces, fewer referral options, and more unpaid or underpaid care, especially in rural and resourced communities. And just paying attention to the chat, I see that there's a question, and thanks, Samantha, for responding to that. So I think we can move to the next slide. And so what are some takeaways, just kind of bringing it back to what are some larger impacts that this is going to have on our communities? It's going to undermine California's progress on birth equity and reproductive justice, all of the work that you all have worked so hard for and continue. We're just going to have to continue that fight even more. There's a lot more at risk too. Additionally, there's increased disparities for Black, Brown, Indigenous, and immigrant birthing people. This also threatens the sustainability of community-rooted birth work that centers trust, culture, and safety. And a lot of the work that you all are really focused in, it is more critical than ever now. So we really appreciate what you all can do. And what we're doing today too is trying to give you some of the information and knowledge of connecting it to, okay, what's happening in policy and how is that going to affect all of your work? And we're here to start to fill those gaps as much as we can. So now I'll pass it to my colleague Samantha to name what CPHEN has been doing in the space and also specific actions on how you all can plug in and help to continue this fight and to continue to do the amazing work that you all do.
Great. Thank you so much, Natalie. And thank you all for the questions in the chat. I think HR1 is really confusing and there's a lot of moving pieces. So as questions continue to come up, continue to put them in the chat. We'll keep answering them, like Natalie said. So you can go to the next slide, please. Great. So I think this brings us now to like, how do we fight back? What are we going to do about this? Next slide, please. And so, I think our CPHEN's answer has been organizing. And so over the past year, so around January, we started organizing with the Fight for Our Health Coalition. The Fight for Our Health Coalition was actually founded during Trump's first administration when the ACA, the Affordable Care Act, was under attack initially. And so, but the coalition went essentially defunct once Biden was elected. And so we restarted this coalition back in January. It's led by SEIU, Health Access, and CPHEN. But then it is made up of over 200 organizations across the state. And so these include lots of CBOs, these include, providers, it includes a lot of different labor unions, really a broad range of organizations. And our strategy over the beginning of this year, when we knew HR1 was moving, through, or really we started before it was actually even a bill, but when it was really an idea. Our strategy was to target 3 Republicans in swing congressional districts in California to flip their vote. And we knew that the margins in the House were so small that if we were able to flip these 3 Republican votes, we could essentially kill this bill. So that was our organizing strategy. Next slide, please. And so the 3 Republicans that we targeted, these might be familiar to some of you who live in these districts. We targeted David Valadao, who represents California 22, which is a good chunk of Kern County. And then Young Kim, who represents California District 40, not 4, California District 40, which is mostly orange and a little bit of LA County. And then California 41, which is Ken Calvert, who represents Riverside County. And so, we were working in these 3 districts, and I'll talk a little bit more about our work. But all 3 of them ended up voting yes on the final bill. So we were unsuccessful in flipping votes. And I'll just briefly say how we picked these 3 specific Congress members was they all won their election in 2024 by pretty small margins. David Valadao especially won by a really small margin, and he is the only sitting Republican member of Congress who voted to impeach Trump who still is in office. And so, we identified him as someone who has voted against his party before. So to us, we were like, okay, he's a good target because he won his election by a very small margin, and he's proven himself to be someone who will go against party lines, at least in the past. We targeted Young Kim because she won by a larger margin than Valadao, but she does live in a purple district. Orange County has become even more purple recently. And she has been an outspoken supporter of the Medicaid program historically. And so that's why we were targeting her. Ken Calvert, I don't think he's a party loyalist. I don't think we really expected him to necessarily go against his party, but we wanted to put pressure on him given that he had won his election by a very small margin in a purple district. And so I think with Ken Calvert, it was less about flipping his vote, but more about trying to flip his voter base to get him out of office in 26. And so those were our 3 targets. Next slide, please. And our campaign strategy, really, we had multiple approaches. I would say the 3 main things we focused on were rallies, a grass tops organizing strategy, and then media. I would say our rallies was our like grassroots organizing, right? And so we had field tables in all 3 of the target districts so that we were really working with the folks on the ground to mobilize and bring out people. And we were like organizing 200-person rallies weekly in these 3 districts. And we did a lot of different like themed rallies. So we had like a rally where we highlighted the impacts to people with disabilities. We had rallies where we highlighted the impacts on children. So each rally had a separate like topic that we focused on. And we did most of these events outside of the offices of these elected officials. And so we were, trying to get meetings with them, but mostly just like trying to make sure they knew we were there. And the why behind this was really we wanted to educate and energize the voter base. Like we wanted to build relationships with the community in the district, make sure they knew what was going on, what their congressional member was doing, and get them energized and activated. And then we wanted to put visible pressure directly on the members to force a response. And this worked. Like we saw immediately the more we did these rallies, like they started locking the door and not letting us into the buildings. They knew that we were there. They knew who we were. We found that they, especially on Kim, every time we would do a rally, she would then release like a video on her social media directly addressing, like not calling us out by name, but directly addressing the talking points that we had brought up at the rally. So we knew that they were paying attention. With our grass top strategy, we knew that we needed to like work with a wide range of partners. And so we couldn't just work with like the nonprofits that we're used to working with. We knew we had to expand our scope. So we worked with providers. We worked with like a lot of different doctors, hospital administrators. We worked with small business owners because a lot of small business owners, their staff, they don't cover health insurance for their staff. A lot of their staff are on Medi-Cal. We worked with local government because local government was poised to lose a lot of money if these cuts went through. And so, even if these are not our traditional allies, we were able to identify that they had a vested stake in this as well, that they would risk losing revenue as well. And so, we were able to like build this really wide coalition. And the reason behind why that was our strategy is we wanted to ally with stakeholders who were allied with the target member to add additional pressure. So we knew like, oh yes, thank you. Great question, Amber. So grass tops, so like when we talk about like grassroots, we're talking about like folks who are like really in community. When we talk about like grass tops, those are folks who are like more so like leaders, right? So that would be like a hospital administrator, like the owner of a hospital, or like a local elected official. So these are not people who are like grassroots. They're not day to day in the community. They have more power in the political process, but they're not necessarily like the decision makers of this issue. And so we worked a lot with local government to pass different ordinances at like the county government level to speak out against these cuts. And the reason we did all of this was we knew that like young Kim, Ken Calvert, David Valadeo, they're not going to listen to us, but they might listen to, the county board of supervisors that they've had a relationship with for 20 years. Or they might listen to the doctor at the local hospital that they love to do photo ops at. Or they might listen to the Chamber of Commerce who endorsed them last year. So we were able to kind of identify like, okay, we might not be the best messengers to these members of Congress, but we can build relationships with people who have a similar interest in this who are closer allies. So that was like that strategy. And then the final strategy was we really had a strong media campaign. We were trying to get media hits in all of these districts weekly, and we were pretty successful in that. So we hosted press conferences, we wrote op-eds, we posted Medi-Cal recipient stories on social media. And really, like, we were collecting, and still are, and we'll talk about that in a second. We were collecting patient stories, um, and then like contacting those folks, filming videos. We were, developing and then helping them write op-eds. Like I said, we were doing lots of press conferences. And the reason where we were like taking that strategy of like wanting to be in the media constantly was we wanted to deliver consistent messaging to the general public and be able to combat opposition talking points while keeping pressure on our target. So, we were able to use the media as a way to respond direct. So every time Young Kim would release a video, for example, she kept saying something around, I don't support Medicaid cuts for the folks it was intended to serve, or the people it was intended to serve. Which, we were able to identify she meant, like, we're not cutting Medicaid for children and we're not cutting Medicaid for people with disabilities, which we know isn't true, but they were able to use that as a talking point. And so then our response to that was, okay, we're going to do a press conference with people with disabilities talking about how this bill would negatively impact them. And we'll do a press conference with child advocates. And so we were really using the media as like a tool to keep eyes on this issue. We didn't want this to happen in the dark. Like, we wanted to make sure that people knew that this was happening, knew how this would impact them. And so that was our like media strategy. Next slide, please. And so we had some takeaways from this campaign, which, like, once the bill passed, we were able to sit down and talk as a steering committee and really think through like what went well and what didn't go well. And our main takeaway was really that our central thesis was wrong. We assumed that we could potentially flip the votes of moderate Republicans because it was something that had happened in 2017 during Trump's first term. We were able to flip votes then, and we weren't able to flip votes this time. We learned that these moderate Republicans who maybe were willing to vote against party line in the past are now falling in line with the Trump administration. And so as we look towards next year's budget, we know that we're going to have to take a different strategic approach to stop this from happening. The second thing we learned was really like we do have a lot of power when we come together. We built this strong coalition. We were able to successfully hold up these regular events. Like, we were doing weekly events. That takes a lot of work. And we were able to get consistent press coverage, and we kept our talking points in the conversation. Like I talked about, like, we knew based off of what Young Kim and David Aldeo were saying, like, we knew that they were aware of our existence and were like directly responding to our talking points. And I think that's a powerful start, even if we weren't able to meet our ultimate goal. And so our last takeaway really is like we need to expand the scope of our movement to reach more sectors and organizations to get our message out wider as the fight continues. Like, I think ultimately we learned that even though we did all this grassroots organizing, we did all this grassroots organizing, we were like hitting all of these different places, like we clearly weren't reaching enough people to move the needle on this issue. Which brings me to my next slide, which is like part of why we're here today. When Amber asked us to participate in this learning session, we were really excited to take this opportunity because we see the value in all of the work that you all do. You know your community inside and out. You are on the front lines of providing vital healthcare to our communities, and we need more organizations and more leaders like the people in this room in our movement if we're going to win next year and the coming years. And, just to speak out on like why you all have such a value add to these spaces is like, one, like you are the trusted messengers of your community, full stop. Like, we can, folks in Sacramento can spend all day twiddling their thumbs trying to figure out what message is going to land in the community. But like at the end of the day, they're basing this off of their own political insight. They're not basing this off of like actually talking to community members. And like that's where you all come in. And I have a background in community organizing. Like I know that having those conversations with community on a daily basis is what's going to help tailor your messaging. It's not like talking in a boardroom in Sacramento, right? So that's like a huge value add. Which and then I think the other thing is like funding cuts are trickling down. Like even if your organization doesn't directly receive funding from Medicaid, any scarcity in funding in one place like ends up impacting the entire ecosystem, right? Like we've seen in the past year the amount of funding cuts to our nonprofits, whether that's through government money or just, like grants falling through, like our work is under attack. And within that, like it's really easy to embody the scarcity mindset of like, okay, now we have to compete against each other, our allies, for limited funds. But we have this opportunity to like shift that scarcity mindset and really like, just to borrow the phrase used earlier, like we're up against these wealth hoarders and like we need to be able to band together in solidarity with each other and demand better and seek out abundance because we know the resources are there. They're just being hoarded. And it's like we're only going to get to be able to access those resources if we're able to like work together. And the last part of this I'll just say is like your voice really matters. The larger the movement to defend and expand our social safety net grows, the more power we have, right? Like if we're able, and that doesn't mean it's going to be easy. Like it doesn't, it's one thing to say like we need to be in solidarity with each other. I think something I've really learned time and time again doing this work is like being in solidarity with each other doesn't mean putting aside the hard conversations. I think it really means leaning into the hard conversations. And I am so excited to be able to build relationships with all of you. To be able to like talk through those hard conversations about how we are going to move forward for our communities. And the power is in that, right? The power is in like building each other's knowledge and building that trust, and then being able to energize and activate our communities to like get the resources that our communities desperately need. So next slide, please. And so with all of that, I'm now ready to really just do an explicit call to action, which is, please, if you're interested, we are always looking for new folks to join the Fight for Our Health Coalition. We hold monthly coalition-wide calls where you'll get updates on what's happening, both like updates like we did today, with keeping up with the implementation of HR 1 and other things coming down the pipeline with the new covered California rates, et cetera. And then also just like that's a space where we're advertising our events. So that's like a pretty low lift. If you're interested in getting more involved in like the strategy and like really activating in this defense work, we also have our field tables and regional tables. We across the coalition there are field tables in I'm going to say every single, yes, they will be in the follow-up email. Great question. We have field tables and regional tables in pretty much every single region that you all are in. So CPHEN itself, we have regional tables in San Diego and Imperial Valley, and we're currently building them in the Central Coast and Sacramento. But then, we also have an all network call that's like statewide. So there's lots of opportunities. And we'll be sending out all of those in a follow-up email. Another thing you all can do is CPHEN hosts community conversations about healthcare delivery. So we've been working on a community conversation series over the past year, we've done about 30, where we work with we work with local organizations, and you get like an $1,000 stipend for hosting. And we have the questions and like facilitators guide all ready to go, but then you do the recruitment. And it's just a really great way to hear directly from like your community members about the issues that they're dealing with when it comes to healthcare. And we are using these conversations as a way to like both like have active conversations with our community about healthcare, do education around different healthcare financing pieces, but then also we're getting policy ideas from these conversations. Like we are hearing directly from community about the issues that they are facing, and then that is what is feeding our policy team's decisions around what we're pursuing. And then lastly, I kind of mentioned this already, but we are collecting stories about the impacts of HR1 on communities. So we want to hear, like, as the covered California rate increases drop, we want to hear from folks about, how that's impacting their ability to pay for healthcare. We want to hear stories about Medi-Cal enrollment, people who are losing coverage. And then also we're collecting stories about medical debt. Because we've been working on legislation around medical debt as well. And we also know that medical debt will likely, as a problem, increase, the more we see cuts to healthcare. So yeah, we're collecting these stories, and what we want to do with this is like really we want to nurture storytellers. I think all of us know the power of storytelling. It's one thing for us to name facts and figures about how this bill will impact our communities, but these are our neighbors, our grandmothers, our children, our coworkers, ourselves who are impacted, and like there are behind every single person who's losing coverage, there's a story, and there's so much power in storytelling. It's like it's a tool that transcends cultural lines. It's part of humanity in many ways. And so I think like we want to not just collect these stories and not have them exist in a vacuum, but we really want to nurture the art of storytelling and work like for everyone who submits a story, we follow up with them, we meet with them, we mentor them on how to tell their story in media, how to deliver public comment. So we we collecting stories is a huge responsibility, and we don't take that lightly. Oh, great, on the medical debt program. Oh, do you know the answer to that, Natalie? And actually, great question, because now this is time for questions. This is question.
Yeah. No, I don't. Joanne, do you have more to say about what you're referring to in the medical debt program? And I also, some of our colleagues are more focusing in this area, so we also could pass the question back to them if we don't know it.
Thank you for the opportunity. And I notice you have medical debt, but I don't, I know that there's a program that exists in the hospitals that they help people clear up and meet their medical debts. And they were just starting to promote that this benefit was available to people. And I was wondering what's going to become of them now, since the debt is going to be insured now. It wasn't just because you went and had, like me, I got a $300 copayment on one medicine. There's only 18 pills. And then people show up in the hospital and they can't cover it, so that they are helping people restore and come out of medical debt. So I was wondering if there was anything in the legislation that would say how they would be affected, or if anybody did the analysis, since most of them are hospital-based. And they were letting people know, hey, they haven't told you, but there were funds available to help you clear up medical debt.
Yeah, so I don't think.
Just before you respond,
Oh, go ahead.
can I also, if you can introduce yourself, like your name and your organization, when you are, providing comments or questions, that would be great. That was it. Thank you, Ms.
Okay, I'm Joanne Russell. I'm here in Los Angeles and I'm an AIM Village Fund grantee, and my organization is Let's Make It Happen. We do social change and research in the African American communities here in Los Angeles County. And like this morning, we were just on a call regarding medical costs. So that was one of the things I was just asking. I'll find out and let you guys know though, because yeah, they're creating quite a firestorm here.
Yeah, and I have a little bit of a response to that. Thank you so much, Joanne, for the work that you do and also raising that question. I think, yeah, to my knowledge, yeah, that medical debt program that you're talking about, as you know, in LA, there's been a lot of work in that space. And so I think, so currently CPHEN is working on a bill that is moving forward and is now going to be reviewed by the governor called AB 1312, which basically, so with the medical debt program that is in hospitals, a big issue is that not a lot of hospitals, not a lot of patients are aware of this. And it's really on patients, the burden on patients for them to know that there's a program to fill out the paperwork. And so we are trying to push forward AB 1312, which will help break down some of those barriers and make people automatically enroll into this medical debt program based on, certain criteria. We can send some more information about that in our follow-up email or to you, Joanne. But basically, I don't know if there's any, I haven't heard about any specific impacts on what's going to happen to the program. I haven't heard that like the program is going to change or anything. I think if anything, we're hoping that, right now, because we know there's going to be so many more people facing medical debt, that this bill, if it gets passed, will be more critical than ever now to help all these people during this time.
Thank you.
Other questions or comments that folks have about any of this?
I have a
One more question. You mentioned that you help and come alongside of agencies who would want to do the town halls and things to get the information out. Would we be able to talk about Medi-Cal and the impact of this bill on our health coverage period, or would we have to stick to reproductive justice?
No, it could be broad, like it could be whatever you were interested in covering.
Okay, because like this morning we were talking about people don't know that their debts, their costs are going to go up. The people don't know that we're encouraging the immigrants, if you're on it, to stay on it, because once you get off, that's really when you won't be able to. So there was a whole, we just talked about this morning. So timely. Okay, I'm on your list. Should I put my information in the chat?
Yes, you can put your information in the chat. I'll also just say to everybody that we'll be sending a follow-up email. And so we'll be sure in the follow-up email to have our contact information so you can reach out if you're interested.
Okay. Thank you, Samantha, Natalie. Thank you both. I will say, I'll, keep us on because we want to honor everyone's time. This was very, very, very informative and timely. So we appreciate the conversation and the information. We have a short survey that we'd like everyone to get to. So if there's time, we can do that. But I think also wanted to give space. CPHEN will be hosting a summit next week, and they have a registration link available just for us. So they're keeping it open just to in case there are some people who would like to be involved, especially if you're local. It's going to be hosted in LA, downtown LA. So if you're interested in these policy discussions, would like more information, or would just like to engage further, that is available. And don't let cost be a barrier. They're very mindful of that. So I think it goes from $65 on to a sliding scale to what is comfortable. So thank y'all again. I mean, this was, I think, really important, and we just want to continue to have these conversations, and thank you for the offerings. We appreciate it.
Thank you so much for giving us the space to have this conversation.
Yeah, thank you, everyone. Really appreciate it. And hopefully this is not the last time that we are all in community and space together and working together.
At all. And I have to say, Samantha, I was impressed by how quickly you saw the chat. When I'm presenting, I can't see the chat. I feel like Mr. Magoo. I'm like, I can't look at anything. So I just was like, wow, I wasn't expecting quick responses, but you did great on that. And we'll make sure the email gets to the group and we'll make sure we're all looped in. So thank you.
Perfect. Thank you so much, Amber.